For my presentation, I chose to study Addison's disease. It is an endocrine disorder where the adrenal glands are damaged, and it can be very life-threatening. There are three types of adrenocortical insufficiency: primary, secondary, and tertiary. Primary is autoimmune, and it is damage to the adrenal glands. It affects all the hormones involved: cortisol, aldosterone, and sex hormones. It can be from infections, HIV, tuberculosis, cancer. The second type of adrenocortical insufficiency is damage to the pituitary. It can be caused by tumors or trauma. It's a disease in the hormone production that causes a decrease in adrenal stimulation. So that means the adrenocorticotrophic hormone, ACTH, does not regulate cortisol in the right way. And then if cortisol is not regulated, you're going to have trouble with blood pressure, blood sugar, the immune system. And then the third type of adrenocortical insufficiency is tertiary. And it is a problem with the hypothalamus and the hypothalamic pituitary axis. This is due to chronic steroid use. Opioids can cause it, asthma, COPD, rheumatoid arthritis. It affects the cortisol as well, and the adrenal glands are damaged. In this presentation, most of my drugs are going to focus on type 2 and 3, where cortisol is needed. And then I'll just briefly mention type 1 every once in a while, but my drugs will focus on 2 and 3. Symptoms and diagnostics of adrenal insufficiency. The symptoms are fatigue, and this is extreme fatigue, not just your normal afternoon exhaustion. Decreased appetite, nausea, orthostatic hypotension, especially hypoglycemia and hyponatremia. Hyponatremia is one of the symptoms that really warrant an investigation and should kind of trigger a provider to think about what's going on. Especially in the elderly, they'll present to the hospital with an infection or pneumonia and their labs may show electrolyte imbalance, but that's often due to adrenal insufficiency. As far as diagnostics, medical history is really important. As one ages, they've been to the hospital more. They may have chronic illnesses or comorbidities. They may have long-term steroid use. For example, COPD, rheumatoid, asthma. These illnesses may require more steroid use, which will affect the endocrine glands. I can speak. Adrenal crisis is an emergency situation that can happen to someone with Addison's disease or adrenal insufficiency, and it is due to the lack of cortisol. It can be caused by taking steroids and not tapering short term, or it can be a chronic condition, someone that takes chronic meds and they have a stress response or an infection. So there are many causes: stress, infection, dehydration, steroid withdrawal, comorbidities, and often previous crises will determine how many more you might have. So if you have one, you're more likely to have another. It can affect all body systems, lead to, lack of blood flow, coma, loss of consciousness. A lot of the causes, there's a big concern for mental stress and people with adrenal insufficiency. So education on mental stress is a big part of anyone with adrenal insufficiency or Addison's disease, how to control stress. And again, that goes along with education on adrenal insufficiency. Someone that is in adrenal crisis needs to get to the hospital quickly. They need fluid resuscitation fast, and they need emergency IV cortisol. Or sometimes if someone with adrenal insufficiency knows that they're feeling off, they have emergency dosing for usually dexamethasone injections, or they can increase their hydrocortisone PO if they notice it early enough. For example, if they're starting to get a cold, they might notice they need more steroids than they usually take when they're on them chronically. Prevention, it's really important to prevent adrenal crises. Education on tapering for anyone taking steroids. Education on the symptoms of adrenal crisis. Make sure if you're on a dosing schedule chronically, you need to follow that schedule. You need to manage your treatment. Preventative care, you need to prevent illnesses and inflammation. Those with adrenal insufficiency and Addison's disease need to carry an emergency card. They need emergency use steroid dosing, and they need to have a support system in case they start moving into these crises. Hydrocortisone is the first choice drug for chronic adrenal insufficiency. So this is type 2 and type 3. It is mostly glucocorticoid. There is some mineral corticoid involved, but not as much mineral corticoid if you were to need more, for example, in type 1, because primary adrenal insufficiency needs mineral corticoids and glucocorticoids. But in chronic cortisol use, hydrocortisone is the first choice. It's short-acting, short half-life. It's metabolized in the liver, and it reaches peak in about 1 hour. The usual dose is 20 to 30 milligrams a day for adults, given in divided doses. And these doses are based on normal body production. So more steroids are released in the morning hours. So the heaviest dose will be taken in the morning. For example, Cortef, the largest dose will be taking, say, 10 milligrams in the morning, 5 milligrams 6 hours later, and then maybe 2.5 milligrams 6 hours later than that. They try not to take it before bed because you want to be able to sleep. You don't want sleep disturbances. In children, adrenal insufficiency is usually temporary, and sometimes it's due to the not tapering or a condition that they go off steroid meds. But they do take it as well, 2.5 to 10 milligrams per kilogram per day, and those are divided doses as well. Children, I didn't discuss this in adrenal crisis, but if they go into adrenal crisis, they do take 2 to 3 milligrams per kilogram, IV or intraosseous, and that's over 3 to 5 minutes for adrenal crisis. And max dosing is 100 milligrams for them. And again, you're going to watch body surface area. Prednisone is another medication taken for type 2 and 3 adrenal insufficiency. It's more of an intermediate acting drug. The half-life is a little bit longer. It still has some mineral corticoid. It's still given in divided doses. Some of the side effects for these are, for prednisone, is mood disturbances, paranoia, brain fog. I actually know someone that was taking prednisone chronically, and they didn't like it because of the paranoia. In comparison to hydrocortisone, the first choice drug, you do also have to watch behavior and mood. Dexamethasone is another drug that I was interested in studying. It is not always recommended. It's very potent. It's 3 times more potent than hydrocortisone. It is no mineral corticoid. So again, in type 1, you would need to take something besides this, for example, fludrocortisone, some mineral corticoid. You can use dexamethasone as stress dosing. It has a long half-life. So you really need to monitor blood sugar when you take this, weight gain, vitals. It's used for adrenal crisis. Again, I know someone that has had adrenal crisis and she takes dexamethasone IV when she does feel like she's going into these adrenal crisis. Growth and weight charts in children are very important when taking dexamethasone. And again, dexamethasone for type 1, you'll need to watch your salt intake. You'll need to address the aldosterone and the mineralocorticoids. Adverse effects and drug interactions of glucocorticoids. Adverse effects you can see here is, of course, sodium retention, hypotension, hypertension right after you give steroids, infection, immunosuppression, muscle weakness, and this can cause osteoporosis and needs to be addressed, especially in the elderly populations. Hyperglycemia is really an adverse effect, and there's several people that were on the border of being diabetic, and adrenal insufficiency can push you into having diabetes, which causes more, you need to monitor that constantly. Sometimes insulin will be needed, or antidiabetics. Drug interactions. So as far as anticoagulants, you need to watch for GI bleeds. Steroids alter the hepatic metabolism of warfarin, so you really need to monitor the INR if you're taking warfarin and steroids. Anticonvulsants, so seizure meds decrease steroid strength, so you need to take more. You might need to take more. Antifungals can really cause infections to worsen if you're taking them with steroids. Interestingly, some cancer-fighting drugs like tyrosine kinase inhibitors actually lower cortisol in the body, and they can also alter metabolism. So they may increase glucocorticoids and decrease mineralocorticoids, or vice versa. So you may really have to monitor cortisol levels in the blood. And then loop diuretics. Loop diuretics can cause severe hypokalemia, and especially taken with fludrocortisone, and that is a drug that addresses type 1, so it's the mineralocorticoid. So really loop diuretics, of course, you need to watch your electrolyte balance. Pregnancy and nursing. You can have a normal pregnancy, but you must be monitored closely. Some of the symptoms of adrenal insufficiency are the same as pregnancy symptoms. For example, extreme fatigue, nausea, vomiting. And things change a little bit during the trimesters. The first and second trimester, hydrocortisone cannot cross the placental barrier, so it is used more often. But you do have to watch medications and, again, close monitoring, because pregnancy symptoms can be the same symptoms as adrenal insufficiency. Too much cortisol may cause more weight gain, more stretch marks, and increased gestational diabetes. Too little may cause more fatigue, nausea, and hyperemesis. It is a pregnancy category C drug, so use with caution. According to our text, there's no controlled data, which I found was interesting. So if steroids if they're given between 24 and 34 weeks, it is okay, but premature labor should be expected within the next 7 days. Also, changes in the third trimester, increased progesterone can cause an anti-mineralocorticoid effect if you're taking the mineralocorticoid for type 1. So cortisol dosing often needs to be increased. Of course, during labor, it's a stress effect on the body, so you're going to need those cortisol boluses, followed by the 50 milligrams every 6 hours after labor. So those are some things that we really need to monitor during pregnancy when taking steroids. Adrenal insufficiency is increasing among the elderly. It may be because the population is aging. It may be more comorbidities, more long-term illnesses such as COPD, asthma, rheumatoid. So cortisol worsens side effects of comorbidities and medications in the elderly. There's more hypotension, blood sugar is affected more often, there can be delirium, confusion, chronic kidney disease, and then cardiovascularly, the adrenal insufficiency can really cause a poor prognosis if not monitored very closely. Decrease doses when necessary because of less muscle mass, less plasma volume. Really watch for like the blood sugar, osteoporosis, drug-drug interactions when they're taking more drugs. Education is a very big part of adrenal insufficiency and Addison's disease. Knowing the risks of not adhering to your medication regimen versus the benefits of living a normal life when taking the medications correctly. Acute versus chronic treatment, knowing if you have a chronic need for steroids, you must pay attention to how you feel. You need to watch your symptoms. Are you tired? More tired than normal? Headache, thirsty? Self-monitor your blood sugar. I know a few people that have adrenal insufficiency have now become diabetic, and they wear Dexcom. They have to monitor their blood sugar every time they take their steroids. So watch for changes, prevent adrenal crisis. We went through all of the emergency management. Watch your stress levels. If you feel an illness coming, you may have to double your dose, increase dosing. And this is very closely monitored as well. Even in children, you will increase a dose if they're taking steroids and they have an illness. Preventing future illnesses, vaccines, flu vaccine, pneumococcal vaccine. See your primary care and your endocrinologist, or if you're pregnant, see your OB and your endocrinologist. You really have to you have to prevent these illnesses and really take care of your health. Again, barriers to adherence begins with your patient, provider, and your healthcare collaboration. In the elderly population, going from hospitals to outpatient to long-term care. It's really important for the collaboration between all of the healthcare providers, especially with a chronic condition. Socioeconomic status, how do you going to afford your meds? Medicare Part D, B, and Medicaid have actually changed a lot, so you have to stay up to date on what pays for what. I know with hydrocortisone, Medicare does pay for hydrocortisone, and I believe there's like a $4 copay because I did check on that. And patients need to be involved with their care, especially in complex medical conditions when there's multiple medications. Providers need to involve their patients, find support systems, find ways with pharmacies to get their medications in an affordable manner, and overcome barriers. Unfortunately, I read in the text that the more comorbidities that one has, there's an increased chance in not getting your prescriptions filled. Decreased adherence. Here's a prescription example for the hydrocortisone, 5 milligrams, and how it is split up into divided doses. And again, anytime you're taking a cortisol medication like hydrocortisone or prednisone, The doses are going to change depending on how a patient feels and is able to live their life and complete their daily activities. If a patient isn't responding well to these doses, they're going to change. So continuous provider checkups and follow-ups on these medication symptoms. This is an example of a medication that is taken daily for adrenal insufficiency. Another medication I was going to discuss was the dexamethasone. It was an emergency injection dose, and I know that my sister who has adrenal insufficiency, one of the reasons I wanted to research this, takes a 4 milligram dexamethasone injection whenever she starts feeling really bad or having stress, illness. And I know all of her cortisol medications went up after COVID, after she had COVID. My spiritual application begins with self-discipline. We only get one body and we need to take care of it. And this applies to all chronic illness, chronic diseases, illnesses. Hebrews 12:11 says that discipline is not always easy. In fact, it's often painful, but it teaches us righteousness and will give us peace. Again, in Proverbs 12:1, it talks about loving discipline and loving knowledge, and hating correction is stupid. So we need to really think about these things when we are educating patients or trying to get them to adhere to their medications. Sometimes we get sometimes adrenal inefficiency occurs because someone took opioids too long, or because they took steroids, they've had these chronic conditions, and sometimes things just happen to us in life and we don't expect them, but we have to deal with them. And it's normal to not want to do them, but we do have to be disciplined. In 2 Timothy, it says we have the power of love and discipline. So we have power. We are not timid, and we can overcome these chronic illnesses. We can live a healthy, happy life. And so we need to encourage our patients that they can get through this. They can overcome struggles like Addison's, but they need to be disciplined. They need to follow their medication regimen, take care of themselves, see their providers, adhere to medications. And then in James, it says, consider joy when we're faced with trials. It builds perseverance. Looking at the goal in the long term. Because God is love in John 4:8. 1 John 4:8, God is love. He only gives us what we can handle, and then when we can't, He provides a way out. And thankfully, we have all this research and knowledge, medications, providers, support systems to help us get through this. And we can help our patients as well. Thank you.